speakers today. Dr. Stephen Luccarelli graduated from Fordham University in 1981 and continued his education at Columbia University School of Dental and Oral Surgery, earning his DDS degree. He completed his clinical specialty training and earned his orthodontic certificate from Columbia University in 1987. He became board certified and was awarded diplomat status from the American Board of Orthodontics in 1998. He's a chairman of the Mid-Nassau Dental Study Club and is a member of the American Dental Association, the American Association of Orthodontists, the American Board of Orthodontics, and the New York Dental Society. For the past 30 years, he's been a clinical professor teaching postgraduate orthodontics at Columbia University Dental School. He owns an orthodontic patent, and he currently maintains his own private orthodontic practice in Mineola, New York. Our second panelist today is Dr. Sam Lau. Many of you are familiar with Dr. Lau, as he's joined us several times in the past, and we're very happy to have him back with us today. Dr. Lau is a professor emeritus at the University of Florida College of Dentistry. He's an advisor member of the Pankey Institute. He is also past president of the American Academy of Periodontology. He's a current officer of the Academy of Laser Dentistry, and Dr. Lau provides periodontists, dentists, and dental hygienists with the tools for successfully managing the periodontal patient. It's my pleasure to have both of them with us today. And with that, I'd like to warmly introduce our speaker, Dr. Stephen Luccarelli.
Thank you, David. Really appreciate that introduction. Hello, everybody. I appreciate everybody coming back for a second round, especially on a Friday evening. That's very dedicated. So we received a lot of great questions from our discussion on Wednesday, and we are going to answer those questions the best we can. And I think the best way of fielding them is for me to group all of these questions into certain categories. I'm going to discuss the 5 categories of why we should own lasers, and I'm going to have one case for each of those categories, and then we're going to answer the questions as I present those cases. So we'll just get rolling here. So again, amazingly, over 90% of all orthodontists don't own a laser, and they really should. It really greatly improves efficiencies and our treatment time, and improves our final aesthetics. There are dozens of lasers out there, and BioLase Epic X is the one that we use the most. In our practice, this is the laser that we love. We love it because it gives us plenty of power, and it's excellent in terms of the types of orthodontic procedures we do. It's very automatic because they've done a great job with the settings. So why don't orthodontists own a laser? Well, for the first reason, and the main reason, is that we really don't get any training in our programs, whether it's dental school or orthodontic school, on how to use a laser. So there's very little exposure. The second reason is that it is mostly because of cost of lasers and training. So as far as the cost of lasers are concerned, you certainly can pick up an inexpensive one that may not have the power that you're looking for maybe $4,000 or $5,000, but I think it's worth a little bit more of an investment. I believe that the Epic X goes for about $8,000 or $9,000. Well worth it because of the great settings that are used for orthodontic care, as well as the power that you'll get from that. It's just really, really easy to use, and they often run promos that actually reduce that fee even more. So the idea of not using laser because of cost of a laser or training, really I don't get either, because it's only about 7 or 8 hours worth of training to become certified. Question about disruption to the practice. You can do this in the main room. Most procedures take about 5 to 10 minutes. And if you are doing a gingivectomy and it's going to take a little bit longer, you just ask the patient to come in the morning when it's nice and quiet. You can be interrupted while you're doing the procedure, see a couple of patients, and then come back. So it's really not very disruptive to the practice at all. As far as injections are concerned, that seems to be a concern for many orthodontists that have possibly you've been out of programs for a while and really haven't picked up a syringe. You know, for the younger guys, it's really not a factor. But the good news is this, that probably 80% of all the procedures that we do, all right, we do not need to do an injection, that we can simply use topical. I use the best topical ever, that's the name of it. And if you do need to give an injection, we often use the Septident from the DentaPen from Septident. It really is very helpful in giving a local, but like I said, 80 to 90% of the procedures you can just do with a top. All right, so it's really pretty easy. You know, and giving a local is also you know, very simple. We usually reserve that for the gingivectomies. Why should we get one? So this is the main reason why orthodontists don't get a laser. And again, 90% don't. And the reason is that I don't think they really grasp how this can improve their practice, give better aesthetic results, make treatment go faster, and also be more profitable. So I think that if we really focused in on the things that a laser can do for your practice, that's where you'll see the benefit of owning one. So we're going to go over 5 quick cases just to show you the 5 categories of where lasers are used in orthodontic practices. You know, soft tissue exposures. This is the most common procedure that we do. It's most important for finishing cases on time as well. So when we have a case like this, where we have a severely impacted cuspid sitting on top of the root of the lateral, and I know you've seen this case on Wednesday, but there are a lot of you that may not have joined us on Wednesday, and it's nice to review it. We will expose this and do our little window in order to place a brace on it and get it away from the root of the lateral, so we don't get a continuation of the root resorption. So 2 reasons. One is we can bring that cuspid into the position that we would like it to be in, and also it will prevent the destruction of the root of the lateral. Again, we will first try to find and locate the cuspid. We'll create room in order to bring that cuspid into its cuspid position. All right, and then we put we make our little laser window. All right, in order to place our eyelet. There was a question asking us if we place the bracket on that visit, and the answer is yeah. We always place the bracket at that visit. So picture us just spending a minute or 2 getting the patient numb. We see a patient, we come back, we do our little laser, we make our little window, we put a little eyelet on there on that exact same day within minutes, and now we're actually starting to bring the cuspid in. One of the reasons you'd like to do it on the same day is you're all set up to do this anyway. You might as well put traction on the cuspid and start moving it in that direction. Also, now you don't have to worry about any of the tissue kind of growing back and then not having enough of a window to place the bracket. So there are a lot of good reasons to do that. When you are bringing a cuspid into its position and it's passing by the root of the lateral, all right, you kind of want to allow that lateral to float around. All right, and so here is the direction of pull that we're going to do. We're going to do it distally and erupt it into the arch. And we're going to pass it right by the root of that lateral. And you can see that that lateral is torquing out of the way of the cuspid. So there were a couple of questions about that. Basically, I want you to picture that by doing the mechanics of keeping the wire out of the slot of the bracket, it's almost as if you just took the bracket off of that tooth. You're allowing the lateral just to float around as the cuspid moves past it. 2 benefits to that. 1 is you're not going to get the resorption of the root. 2, the cuspid's going to move more freely. The reason we don't just take the bracket off is it's just aesthetically, it doesn't look great in that part of the mouth. So we bring the cuspid down into the position and we erupt it into that spot, again, not engaging the wire into the lateral bracket. And now we do a second laser procedure. There were questions about billing in terms of doing a second laser procedure, and we'll talk about billing in a minute. But often I need to do more than 1 laser procedure on a severely impacted cuspid or a horizontally impacted second molar. I don't charge additional fees, whether a patient is paying or the insurance. I submit once or I charge once. I don't like nickel and diming. And whatever it takes to finish what we were doing in the first place, there's only one fee for it. And we'll discuss how we manage that as well. Now we're putting the bracket on, and a real bracket on, and now we can erupt that into the arch. And 6 months later, we had a cuspid that was sitting on top of the root of that lateral. 6 months later, we've got it into the position where it can erupt. And we have been able to save the root of that lateral. And you could see how there's minimal root resorption or apical resorption. And I think that if we had not done the procedures that we did, we would have had significant resorption. A lot of people had questions about this particular case, just curious as to why those centrals didn't erupt. And he's 11 years old. He's in 6th grade. How is that possible? Well, he has very fibrous gum tissue. And sometimes teeth just don't have the eruptive force to break through that. So, they kind of just sit there, or they're exceptionally slow. And I think that you're doing a tremendous service for these patients by allowing the centrals and the other incisors to erupt through this tissue. It'll be healthier. They'll come in timely. It's so easy to do. And for this case, it's really a no-brainer. It's really exactly what you should be doing. So you can see the centrals are just sitting right there. And and we're going to just kind of trim the tissue. And the way that I always kind of look at this is again, there's a balance between the eruptive force and the resistance of the fibric tissue, and whether or not those teeth can break through is always the question. So I always look at the little window that we're placing on situations like this. I think I mentioned this on Wednesday. It's almost like putting a hole at the bottom of a grocery bag. And as soon as you make that little hole, it kind of just opens up, and it allows for those teeth to just break through. And yes, we did throw some brackets on that same visit to help the eruption of those permanent teeth. All right, so we've got our little windows. We decided to then clean up the cuspids a little bit, all right, make them look like that. And then we throw on brackets anywhere that we can. They don't have to be in the right position. They're just a handle to be able to put a little bit of eruptive force to help bring those teeth in and have them come through the tissue. And 6 weeks later, you can see how these teeth have greatly improved. And that little grocery bag just kind of opened up for those teeth to come in. Now we can put regular wires in and brackets on, and we go from here to here in 4 months. And I think that is just a tremendous service to provide for your patients. And if you don't have a laser, there's really no way for you to really do this. You're referring this out. Patients have to go to their oral surgeon or their periodontist to have this done. Patients really want to stay in-house, and there's no reason why you shouldn't keep this in-house. Not only because it's very rewarding, but there's financial rewards as well. Again, you're going to spend, maybe $8,000 or $9,000 for a laser, but on one procedure, you can have the ROI of $1,000. So this is what code we use. There were a lot of questions about insurance, so I will take a few minutes to go over that. At the visit before, we're going to plan on doing the laser. So let's say I see a patient, I say, okay, let's talk about a laser procedure. I explain it, I tell them all about it. It's not going to hurt, there's no bleeding, it's really easy, it takes about 15-20 minutes, and then we can get some brackets on. All right, if they're interested in going forward, what we say is, okay, fine, let's set up an appointment in the near future for us to actually do the procedure. We will submit to your insurance company that we're going to be doing the exposures. We'll see if they cover it. If they cover it, great. If they don't, it's a few $100. For this procedure, if it was not covered, I probably would have charged the patient $300 or not charged them at all, because this is something I really want to do. It's the right thing to do. And if they can't afford to pay for it, or for whatever reason they decide not to, I probably would just do it for nothing, because I think it's the right thing to do. So We submit to the insurance. If insurance is going to pay for it, then the patient pays nothing. You know, if they're not going to pay for it, we call the patient and say, look, it's going to be $300. Are you still interested in doing the procedure? And 99.9% of them will choose to do this for $300. All right, second molar impactions. We unfortunately see this way too often. We do see it a little less now that we don't use bands on first molars, but when we see this, it's very disruptive to our cases. All right, so we have the second molar. We really have very few options. The surgical intervention is just simply fraught with problems. Root fractures, devitalization, things like that. Or we can orthodontically upright it. We went over this the other day. We just put the bracket on really as crooked as we possibly can. And now we start uprighting the tooth. We have a little kind of a spring built into this, all right, in order to have more having more wire than interbracket distance. And that creates our nitinol spring. And there were a lot of questions about this as well. Do we charge for that? I wouldn't charge the patient for it. I think it's our responsibility to align our second molars, and it's all part of taking on the responsibility of the case. We do submit to insurance. If insurance happens to cover it, great, but I don't really look at it like that. I look at it as though this is our responsibility to fix this type of a problem. And there were a couple of questions about, with the second molars, there were a couple of cases where I did 2 or 3 lasers. Again, we would only submit once to the insurance company. And in this case, I don't charge at all, but even on other cases, if they required a second surgical procedure or laser procedure where we had to do some touch-up, I don't charge for that either. All right, so I really only charge once, and I think it's a great service to provide for those fees. So you can see how the second molars are uprighting, and look at the difference. Look at how we have saved that second molar just because we've had a laser. And here we have, gingival recontouring. We have a case that has a very, very thick biotite. And you could see that there is a lot of hidden enamel underneath that tissue. We can treat this case for a couple of years and 21 months and have a beautiful, beautiful alignment. All right, beautiful alignment, good occlusion, good inter-incisal relationship, but the smile just looks okay. Great case to do a gingivectomy. All right. This was the laser procedure we did. I showed you that the other day. All right, and this is half, and here's the other half. And right away, it looks nice. As the patients are leaving the office, already it looks better. So we go from here to here in 45 minutes. All right, and then 3 months later, this is how nice the case ends up looking. Tissue looks extremely healthy, and we have a smile that looks so much better than it did before. All right, and it was also rewarding financially. That procedure, which took about a half an hour, 40 minutes, no more than that. Yes, I did use an injection there. We did not do that procedure with topical. Most of my gingivectomies are with an injection. That was there were a lot of questions about that. But the way that you could kind of look at it is for exposures, just topical. For gingivectomies, you're probably going to need to inject. Again, the visit before we start discussing this. So when we're thinking about doing a gingivectomy, we first discuss it with a parent. It's an optional procedure, all right? And we explain that we can submit to the insurance company and find out, get a pre-D and see if they'll cover it, all right? If we'll set up the appointment to do the gingivectomy, and we'll let the parents know that the insurance company has decided to cover it, or if they haven't, the fee is $500. That's what we charge for both quadrants, upper 4 to 4, all right? This is the code that we use. There are a lot of questions about that. What code do we use? All right, so we use this code D4210. All right, we put down the charge as being $800 per quadrant. Now, the reimbursement is going to change based upon where you're located. We're in New York, so our reimbursement might be a little bit higher. They need to be 4 continuous teeth in the quadrant. That's what we've noticed from most insurance companies. So if we do an upper 4 to 4 where it's 8 teeth, you're doing 2 quadrants worth of laser procedure. All right. And in this situation with the 2 quadrants, insurance paid $924. So those are kind of the rules. We also have to do some probing. For what I will do often is, if parents are interested and we're going to set up an appointment, I will quickly do some probing. I'll probe just the facial surface, 4 to 4. So it takes 2 minutes. You chart it. All right. They're looking for pocket depths of a couple of pocket depths of 4 millimeters, 5 millimeters, somewhere in that ballpark. And then you have it there. Some insurances don't require it. Some insurances do. All right. Mid-treatment recontouring, we're dead before we even start. All right, we're dead in the water. All right, 3 months in, and now we have to pop the brackets off, and we'll do our gingivectomy. There were a lot of questions asked of me about doing laser procedures with existing inflammation. Well, that's the perfect time for us to be doing it. It's a very simple procedure. This case has tremendous inflammation everywhere. Look at that. So this is the time to do it. This is how a patient would recover. We'll reduce all this tissue, all right? And we'll be able to get our brackets on in the right place, and we're gonna make the inflammation go away. So this looks so much better after we do the laser procedure. So the answer to that question is absolutely. You're helping this patient by reducing the inflammation and making everything cleansable. So now we can get our brackets on in the right position. All right, and aligning, and brushing is still not great, but not bad. And there were questions about, do I have to go back and touch this up? Absolutely. I'll go in, I'll take my laser out, I'll put a little topical around the 2 laterals, and I'll just touch that up. And I certainly would do it before I go and have bonding done. It's really easy. It takes just a few minutes. You just put a little topical on. It can't take more than 5 or 10 minutes to do that. And it's a tremendous service that you're providing, not just to the patient, but to your restorative dentist, because now they're working in a very clean area without inflammation, and they can make proper emergence profiles and really do a beautiful job in restoring those teeth. And then the last reason is laser assisted Invisalign. I think that this is going to be one of the biggest reasons for us to own a laser. We're doing more and more aligner treatment. We want to give a great aesthetic result. So there's one big benefit to doing a laser on aligner treatments, is you're going to get a better aesthetic result. But the other reason is it's going to make Invisalign and aligners work better by providing more surface area. So you get 2 benefits to that. So right away, when we do a laser on this patient, he's going to look better, but also it's going to make the aligners work better. So compliance and surface area are the main reasons why aligner treatment are successful. When you have minimal surface areas, you have lots of problems. Aligners don't stay in well, they don't work well, they don't grab teeth well. So when we can bring the gingival tissue up higher, all right, we have much more ability to have success with our aligners. So now you can actually see a height of contour here. You can see how the aligner will snap over those teeth. You can put your power ridges in the right place. Your attachments will work better. All right, so here's where our aligner was. Here's where our power ridge was. And here's where the attachments were. So there were a lot of questions on when I do this when it comes to aligner treatment. So I don't do this procedure at the beginning. It's just too complicated. I get them started, all right, and then once they are ready for a refinement, all right, that's the perfect time to do your laser procedure. You might do your refinement a little earlier than you expected, and that's perfectly fine as well. All right, so basically, the frenectomy. Oh, the frenectomy on this case. All right, so we did do the frenectomy. In this particular situation, the frenectomy was not covered. All right, so they required that the frenectomy be done on a different day at a different time. You couldn't do the frenectomy at the same time as doing the gingivectomy, so they only paid for the gingivectomy, which is perfectly fine. I would never numb a kid up twice in order to do a frenectomy on a separate day. All right, so there were a lot of questions of, do I do the frenectomy at the same time? And the answer is yes. Do I worry about getting reimbursed for it? No. You know, I just think it's the right thing to do together. So I think that's about it for me. All right, and so you can see how nicely aligners fit when we do the gingivectomy, and how beautiful the aligners look. And I'm going to turn this over to Sam to discuss biological width, frenectomies, and billing. Sam?
Oh, yes, I'm just trying to share the screen here. So Nathan, if you could, you're still sharing, Steve.
Dr. Luccarelli, if you could stop sharing, then Sam will be able to.
Sure.
Yeah. Perfect. Excellent. Well, thank you, Steve. It's a real pleasure to have an orthodontist that is so devoted to not just adding an extra benefit to his patients, but also utilizing laser activity. Let me just do one thing here. Excellent. Perfect. Here we go. I actually spend a couple of days in orthodontic clinics and have done for about 7 or 8 years. And I'm always appreciative. As a periodontist, I had many, many patients referred to me from orthodontists, but it was only when I this, that only 5% of orthodontists have lasers, but if you talked to folks like Steve and others that are orthodontists and appreciate what you can do with a laser to take gingiva and truly make it to where you are literally helping the orthodontic process. So to me, this is a good example. You don't see traditionally, or 20 years ago, you know, I would make a little window in here and put a bracket. Notice that with a laser that I'm able, and this was done with a diode, I'm able to not only expose it, but go actually underneath the cingulum, because I have a theory for you. It's sort of common sense. And if you saw Steve's case where, you know, he's moving a coronal gingiva to allow second molars to erupt, why not give the body a chance to erupt teeth? So why not go underneath the cingulum and make this very clean to where now this tooth can erupt. We can put a bracket on it and move it with speed. I may be wrong, Steve, but I do believe probably one of the, at least when I look at products in the last 5, 7, 8, 9 years, one of the things orthodontists want to do is move teeth fast. I'm not saying I move them fast and not move them right, but there's so many products out there about moving teeth fast, because I would assume that if it's children in orthodontics, the child wants the ortho done fast, but the parents want the ortho done fast. So I'm going to look at 3 things with you. I'm going to look at crown lengthening and frenectomy, and then we'll touch a little bit on billing when we talk about crown lengthening, because I think that's where sometimes the confusion lies. And so in crown lengthening, there are ways of doing that. You can do a gingivectomy, and we would all love to do gingivectomies. They're easy, they're quick. They can be done with anything. They can be done with a blade, electrosurge, a laser. But let me reinforce, and this is not the periodontist in me, this is the dental practitioner in me. when you believe that you have a situation with biologic width and you need to do something with osseous, then you've got to do a flap, or you've got to do closed flap osteosurgery, ostectomy that we're going to discuss. Also, you can't just make teeth look fantastic if you end up with minimal or no attached gingiva. And so when you're looking at these cases, it does get complicated. Where's my attached gingiva level? Where's my frenum? Am I going to be able to get my Godin proportion? My 1 to 1.6 ratio? And so when I'm thinking about this also in the orthodontic market with teenagers, you're thinking about active versus passive eruption and going through all those kinds of things as you go through this. So I want to just share just a little bit with you, because when it's just supra bony, but on the other hand, I see some of my colleagues that will do flap and osseous surgery on an 18-year-old in an active eruption process and remove 3 millimeters of bone apical to the CEJ. I am convinced that when that person becomes 30, 35 years old, they're going to have recession, especially if it's thin gingival biotype. And right now, in the last 2 or 3 years, not sure what's going on, probably implants, but we're talking more and more and more about gingival biotype than we have ever had before. So it really is about biologic width. Now, in the John Coyce model, which is typified here, and the models of others, when you look at it, it is that 2 to 3 millimeters that one needs between the gingival margin and where the osseous is. Now, I learned this the hard way, because I would be making these kids or whatever look fantastic. And then 9 months later, they would come back and say, I think my teeth are getting shorter. Well, the teeth aren't getting shorter. It's just that the body says, we're going to correct for the fact you didn't deal with a biologic width, and we're going to move the gingiva coronal. The gingiva doesn't ever move apical, it moves coronal. So by maintaining and really, and I'll show you what we mean by that. So not only here are we, let me just get back to this. If I can, maybe. Here we go. So not only are we looking at contours, we're looking, where's our attached gingiva? But even after we have done our GV, we're going in and ensuring that there's a good 2 millimeters to 3 millimeters before we hit osseous. We're sounding the osseous, because if we do this and we're right at the osseous, my friends, I can tell you it will not look like this in 9 months. Those teeth, those clinical crowns would definitely be shorter. So with that, these are some fairly radical cases. But if you look at the upper left, look where the gingiva is. I mean, significant, almost what we call idiopathic gingival fibromatosis. This is immediately on the upper right. I wanted to, just for drama, I did something that was asymmetrical just to show you on one side what we've done and what we were about ready to do. On the lower left, you see after we've completed it, and this was done with the diode. And over on the lower right, you see, and these wonderful cases that also Steve showed you, that is actually 1 week later. So the healing is phenomenal. I always like to give little pearls. If you don't know about CHU, C-H-U, CHU's T-bar, it's phenomenal for this kind of thing. And this is what I use when the parent comes in with the child post-ortho. The teeth look fantastic. The orthodontist has done a phenomenal job, but the clinical crowns, I mean, are just so short. You know what the beauty of this thing is? This already does the golden proportion for you. So if it is, and this is what I put on the child, the teenager or the adult, and I say, if it has to be this wide blue, then it's got to be this height blue. And actually what they've done is they've already done the algorithm for the 1 to 1.6 ratio. And it's shocking how actually short clinical crowns are. So with that, what we will do is then let's talk for a moment about coding. And again, for you international folks, just bear with us, but for all of our domestic folks, believe me, this is very important to them. You can use gingivectomy codes like the 4910s, 12s, but I reserve those codes personally for me for codes when I'm trying to get gingiva away from teeth to be able to put appliances on, or the wonderful cases that Steve demonstrated. But when I'm doing aesthetics and when I'm doing gingival recontouring and it requires a flap, then that is a 4240. And so you can see this is a case of Danny Melker, outstanding case. This case cannot be done with a laser, my friends. This is flapping osseous. But when you're doing gingival contouring for anatomical crown exposure, then I have a tendency for my US friends to use 4230 or 31, depending upon the number of teeth. And you'll see that the amount of dollars is substantial, with a median of about $1,161. So, but when I'm doing, and by the way, those cases that when you move into osseous, you can't do those with diodes. You've got to do those with erbium chromium YSGG lasers. Because if you'll look up there, notice how I'm going in with the tip, going into the gingiva, going into the sulcus, and I'm actually removing bone to ensure my biologic width. Now, those cases, again, a whole different animal. Those cases is clinical crown lengthening, hard tissue. Remember, we're going in and doing our osseous. And in those cases, it's 4249. And again, you can see some of those median fees. At the end, I'm going to give you my email, just as a courtesy to you. We will send you a BioLace billing guide if you would like, but I will give you that email at the end. So these are cases when I'm doing like adult, the orthodontic stuff, I'm actually not just freehanding it. I'm in there literally most of the time with surgical guides that I've created before I do it. So it's great. I slip the guide on. I make, we do what we talk with very little water, or if you're a diode, almost hemostasis setting, and we just do our marks, we take the guide off, and then we do our business. Our second area is frenectomy. Now, there is not a single procedure ever that takes, in dentistry, that takes as little time and creates more return on investment than a frenectomy. If you're spending more than 5 minutes on a frenectomy, I'm not sure what you're doing, because you're way overdoing what this thing takes. Now, this is not a hands-on course, but I'm going to give you a couple little pearls. When you're doing frenectomies, you don't start here. You don't start here. You actually start here. And no matter what anyone tells you, and I will send you the video of this if you would like, you literally just take your laser back and forth, 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 putting significant tension. And as you do that, it's going to open up into this incredible diamond to where what was here coronally is now up here. And what you always do, you can probably see my little line across there. That is what's called periosteal fenestration. And that's, I'm drawing a line through the periosteum, actually to the osseous. And when you do that, my friends, that frenum is not coming back. One of my pet peeves about folks who do frenectomies and don't really know what they're doing is they're doing frenectomies. What they're basically doing is like taking scissors or even a laser, but that is not a frenectomy. These are frenectomies. Do you notice how up here, this is never, never, never going to come back down? I mean, it's impossible for it to come back down. I don't know if I have ever done a frenectomy twice on the same patient because we do it right. And so here's a case to where, and this was one of the questions. Here's a case, this was a diode case about one of the orthodontic residents at University of Florida did this, and I was overseeing the case. They did a wonderful job maintaining their keratinized gingiva. We looked at our 1 to 1.6 ratios. But notice, you may not think that the frenum is involved until you start removing gingiva. And the more you remove it apical, you say, whoa, guess what? I'm in a frenum. Now, sort of like Steve giving stuff away, so do I. So I'm not going to charge a patient additional fee for a frenectomy here because this took me like 2 minutes. But can you see that I wanted to maintain a zone of gingiva between the frenum that was there and that margin? Because if you're not careful and you don't do the frenectomy, when you pull up on the lip, you will see that new gingival margin that's now more apical move. And that is what we don't want in these particular cases. And so here's another case that I oversaw with a orthodontic resident. And I think this is also true for Columbia. I think, Steve, you've got a relationship with Columbia, if I'm not mistaken. And those residents, there's very few orthodontic programs in the country. But I know Columbia, where Steve is, and I know where Sam is at the University of Florida, our residents in orthodontics leave being competent in the use of diode lasers in the procedures that we are showing you. So lastly, as I add some icing to the cake, someone always asks me, so well, after we do the procedures, what's the post-op? Steve did a very nice job of going through that. I want to add a little bit. We use Periosteal gel. This is a anti-inflammatory gel that also has menthol and thymol in it, a little bit of xylitol in it, but we use that on all of our cases. We provide a patient with like a 12 milliliter little pump, and they use it 2 to 3 times a day. I know some of you have heard about vitamin E. Vitamin E, there's really very little science. I want them using this anti-inflammatory gel 3 times a day till they actually complete it. Now, don't use chlorhexidine. Chlorhexidine destroys fibroblasts. That's the last thing you want to do on these particular cases. So here's the case, the top. We're doing a little bit of aesthetics, cleaning up a lateral, recontouring a central, and that's 5 days later between using the laser and also using the gel. If you would like more information about this gel, you can get that information from periosciences.com. Along those lines, we also are now starting to use oral probiotics during orthodontic care. And there's actually a couple of studies on that. This is simply a mint that the patient puts on their tongue. I swish it around for about 30 minutes. It runs out the organisms that are going to create that hyperplastic gingivitis that we see so much. So between the gel and the probiotic, we do that quite a bit for our patients. And sometimes when we see that hyperplasia, we've got them on both. In fact, there's a great research from Baylor in angle orthodontics, by the way, actually using the Periosciences gel. So again, if you go on periosciences.com, you will find more about that. If you go on Probiora, you will find more about using probiotics. So therefore, lastly, I would strongly ask you to get on PubMed and start looking at publications of one of my favorite topics called photobiomodulation. Somewhat controversial, but you will begin to see some incredible good research about how teeth can be moved faster using what we call almost like low-level laser therapy. And if you talk about the diode epic that, that Steve was relating to, if you do get that kind of laser or whatever laser, make sure they have the attachments for photobiomodulation, because that's what we're doing. Very, very low levels, and also very, very short, almost like 30 seconds. And so we're having patients that every time they come in for a tray change or elastic, what have you, we're using that in the affected area, actually intraorally. So lastly, if you're going to look at diodes, and please you should, I can't reinforce more of what Steve was saying, but there are companies out there, especially now, that I would guess we would say aggressive in selling these kinds of lasers. Here is one of them from BioLace. I mean, an incredible deal, no payments until 2021, rebates, things of this nature. But if you do buy these diodes, please make sure they have training, and Academy of Laser Dentistry training or good training from them, but also be sure and get those attachments. So in fact, it's not one I was going to give you, but I'll just tell you my email. If you want to get a billing guide or any questions that you may have, would be slow@dental.ufl.edu. And I think Nathan might even put it on the chat as he's done before, but it's slow@dental.ufl.edu. And I will be more than happy to send you a very good billing guide from BioLace that is laser oriented. So Steve, great cases. Thank you very much, my friend.
Thank you, Sam. And just as a follow-up, just as I had mentioned on Wednesday, we do not do any hard tissue recontouring. All of that gets referred out to a periodontist like Sam. So when we are probing, we're looking for altered passive eruption or hypertrophy. And so we will probe and try to find out where the CEJ is, look at x-rays. If we think that there's a lot of bone around there, interfering with our ability to do our gingivectomy, then we just send it out, and a guy like Sam will do a flap and do the recontouring so we don't invade on biological width. But
you know, Steve, one thing that's great about these cases too, especially that post-orthos 16, 17, 18, 19-year-old, is on many of these cases, especially on the females, the biotype is already so thin that really, there's actually there's not a lot of osseous there. There are dehiscences, and that's what makes orthodontists be able to win so well without referring to periodontists, because all I'm going to do is a gingivectomy too. So many of these cases are already set up for you with thin biotype, probably dehiscence, but I will caution you, because everything I tell you that is a mistake, I've done. I had one case in which I just didn't even think about occlusal wear, because I just didn't think about occlusal wear being that with someone that young. And so I promised the mom, everybody, about how I could make these teeth so long. And guess what? I got in there. And if you're not careful, not looking at occlusal wear, what do you think I got into? CEJs. My friends, you do not want to expose a CEJ in these cases for many, many, many reasons. First of all, if you do, then you've got to send it to a periodontist who's going to say, why did you do that in the first place? So you're going to have egg on your face, so don't do that. So we have some questions.
We sure do. Dr. Lau and Dr. Luccarelli, thank you again very much for spending the better part of this hour really diving, I think, quite deeply into the questions that were generated on Wednesday. We have a lot of positive comments to those responses and some new ones as well. I do always point out, Dr. Luccarelli, that you're drawing a very international audience again tonight. got Iraq, Mexico, the Netherlands, New Zealand, Australia in the house. So you're popular all over the world. And thank you for joining us from all of those places.